Hello, everyone. Welcome to the Innovation Accelerator's Future of Healthcare podcast. I'm your host, Brian Silverstein, the Chief Population Health Officer at Innovaccer. We're honored to have Emily Olson and Dr. Emily Guth from Evergreen Nephrology. So, Ms. Olson and Dr. Guth, would love to learn a little bit about each of you before we get started. Could you tell us a little bit about yourself, perhaps what you're passionate about, and a little bit about your role at Evergreen?
All right. So truly best practice care for patients, like being able to do what we need to do with the patient. So taking that patient at the right time with the right intervention is like the key of what we do. Like that's truly what I'm passionate about, doing what's best for the patient. And we say that as advocates, like as an RN, we're supposed to do that, right, innately. But I think sometimes some of the situations we're put into within the healthcare system and the restraints that are put in place, it limits us to do what we want to do right out the gate. But our model supports being able to do that. And that's what I love about what we do at Evergreen.
That's amazing. So how in your role are you able to take that passion and bring it to life?
So as the VP for care management, I'm able to look at the whole bucket of care management. So that's truly everything. So what Emily brings to the table as one of my team members, and then we have another individual, like we're all collectively able to look at what's going on with the patient and piece together the different interventions that we can put in place. So care management it's what we do. It's everything. It's the full umbrella within the value-based care arena. And it truly encompasses the holistic care, which again, like I said, when you can do that for the patient, it's the best scenario. It truly is.
Exciting. I'm going to be really excited to learn more about it. Before we do that, would love to hear a little bit about you, Emily.
Yeah, so similar to Emily, I work on the clinical innovations team, and I'll just go ahead and preempt the other question here. My passion and my experience, a lot of it comes from behavioral health. Behavioral health is something that has such a big impact on every one of us every day, and yet it's something that we're still a little bit scared to talk about in a meaningful way in healthcare. So what I really believe in, the roots of behavioral health is you can't do anything with mental illness until you get the patient buy-in, because it's not like some of our other physical illness where you can just run a test and do a diagnosis. You have to get the patient engaged to understand what's going on in their head. And so taking that, really integrating it into what else we're doing. So we work for a nephrology-based company, and so typically we are pretty good at taking care of the kidneys, but a lot of times what we're not as good at and we don't have the experience, time, and resources for is really thinking about, okay, we know we're not getting the results we want around the kidney, but what else is going on in this patient's life that is a barrier? We may be thinking about optimal start, so making sure that someone has a semi-permanent access before they start dialysis. But if they are depressed and they're not getting out of bed, the likelihood of them being able to follow up on the appointments and the medications and all the different pieces is slim to none. And so we cannot be effective in our current world without actually, and it goes past just identifying it and saying, okay, we see these, but like actually, how are we thinking about once we know it's there, what are we actually doing about it? And how are we making sure that we're addressing those barriers before we try to push on with some of these other things and outcomes that we want to do?
Absolutely. It's interesting. I think behavioral health is something that for decades, it's kind of been in the shadows, and everybody in healthcare knows that really is the key. And so I'm really excited to learn a little bit more as we have our conversation about how you're integrating that into your care model.
Yeah.
Before we dive into that, then in obviously Evergreen, you're nephrology specific. Do you want to maybe share on a high level, what is Evergreen trying to do?
Yeah, so I think we are trying to, I know what we're trying to do is create a better experience for an individual living with kidney disease. These people, it's really interesting when you look at statistics, kidney disease is very prevalent, but when you look at the amount of dollars that go towards advocacy and research and some, it's like slim to none. So there's a really big disparity there. And then when you look at other inequalities. You look at race, for instance, people of color are far less likely to get transplanted. So there's so many what I'll call somewhat low-hanging fruits in this area that really can create a better experience for the patient. And the really, really beautiful thing about value-based care, which I'm sure we'll talk about later, is that you can do this as a provider, you can, as a health plan payer, you can do this, you can do what's right for the patient and make their quality of life better. And it's financially beneficial as well. So that's like really the beauty of value-based care when we think about it in really simplistic terms is I can do what's right for the patient and I don't have to worry, am I going to have enough money to keep my practice lights on? And it's a really wonderful way. So often we think of, either it's a choice of either I have to do what's right for the patient and I'm just going to suck it up and figure out another way to pay bills, or I'm going to, worry that my front desk person can't feed their family or things like this. But this is really when you do what's right for the patient, the money will follow, which is a really radical and new way of thinking about healthcare entirely.
And the best part about it is when with the model that we have put in place, like the more we do on the front end, you actually then improve the quality of life of the patient, right? So we have our different buckets of our patients with, kidney disease, and then they end up with end stage. We will get to the point with driving with the initiatives that we have that we can extend them getting to the end stage renal disease where they have to pick a modality. They're on that of choice. So if we do really, really well with the CKD 3, 4s, before they go to 5, like we can then extend the quality of their life, which is, it's one of the greatest things with that population of patients to be able to help them to know that by educating them, giving them the resources that they need up front, we can help them get to where they need to be to extend that quality, to hold off on, going for hemodialysis because they're doing everything right, because they know what to do and we're giving them the resources to do it.
And I think the patient empowerment piece is a really big focus of Evergreen as well, because patients can't do this if they actually don't know what's happening. So you'll find patients that absolutely can tell you what their GFR is, but they don't necessarily know, does that mean I'm going to die next week? Or does that mean I have to choose dialysis next week? And so coming in early to the process, because at the end of the day, kidney disease progresses in a very linear way. And there's only so many different routes you can choose. And so talking to the patients about that earlier and also empowering them and say like, hey, look, this isn't a predestined road. There is a lot of choices. You have the choice to dialysis, and even further, what kind of dialysis? You cannot do dialysis. That is also an okay choice for you. So thinking about palliative or conservative care management, you can do nothing if you want, and we'll talk to you about what that's going to look like. And you can do, or you can think about transplant and what might that look like? Are you actually a candidate? So that you're thinking about this long before it's crisis time, and you're like, hey, by the way, your kidneys are really failing at this point. You got to make this decision tomorrow. And that sets in motion a whole bunch of undesirable outcomes. And so really empowering the patient, truly, a lot of people talk about patient-centered care, but doing patient-centered care is very differently. It may mean as a provider that you're saying, hey, what you're choosing makes me uncomfortable, and I'm still going to support you fully in that because I know I've given you all of the realistic expectations and education you need to make that decision for yourself. But I'm going to still do that. And that's a very, very hard thing when we think about sort of the transition of fee-for-service to value-based care. Oftentimes we talk about the payment method, which is obviously very, very important, and incentives. But the paradigm and mental shift is the biggest barrier, I think, across the board. And this isn't specific to kidney care, is like, I have to think differently. I have to think differently about pouring a lot of resources into this patient up front and trusting it's going to come out tenfold in 2 to 3 years, because it's not an instant gratification thing. And fee for service over many, many, many years has like beat that into us. You do this, you get paid. You do this, you get paid. And this is like, you're doing all these things and you may not see the result. Like if we're truly delaying kidney disease, you're not going to see that payoff for quite some time because they're not going to be doing things, which is good. And so I think that mind shift is like the biggest hurdle we have in value-based care, especially when in today's world, a lot of providers are like, okay, this portion of my patients are value-based care and this one is still fee-for-service, and having to move back and forth and saying, okay, this population of my patients gets better and more inclusive care, that's a really hard thing to do. So I think when we think about challenges too, that's something that isn't maybe as obvious but I would say is like our number one hurdle is helping people to disingrain something that's been programmed into them. Some of our providers have been practicing for 35 plus years, and they're just now having to retrain
Absolutely.
that thought process.
There's lots of challenges, and that's part of the reason why it's exciting. Tell me though, from the provider point of view, I heard some of the challenges. Tell me if I'm a provider and you're telling me about your model, how's my life going to be better?
Oh, and I think that's actually one of the number one things, like and Emily said it too, like they're good at renal, right? That the nephrology patient, they know what to do for the kidneys. And we've had the opportunity when we're looking at our different partners and we have the conversation beforehand with our deep dives and stuff, like it is the social determinants. It's when you look at a patient and you see a synopsis of them for 15 minutes when they walk into your office, you're hearing what's going on, but they can address the medical pieces, right? When they leave and they're talking about they can't get here because of transportation, or the medication you ordered is too expensive, or there's a barrier at home, they're the primary caregiver for another individual that actually they make the other individual their priority. It's those pieces that we're able to show to the providers to say, hey, this is what we do. Like, this is our space. This is value-based care. We can help with all of those aspects. We have the social worker. We have a registered dietitian that can review that information with the patient for dietary things. We have a pharmacist that can take place with that. We have our health coaches and our nurse care managers that jump in. So you have all these team members collectively. And we had one of our partners say, like, it's literally putting a hug around the patient. She said it was the best thing she could explain to the staff is, here's a service and we get to hug them with all of this and give them the opportunity to succeed the way that they need to.
It sounds almost too good to be true. And so how does the business model work to support this? And, it's clearly all of these additional services really can make a huge difference, but oftentimes those individual services are not paid for. And by doing those services, you're going to avoid a lot of unnecessary care, which unfortunately is revenue. So how does this business model work?
So I think the idea is that what we know is that there's an incredible amount of waste happening. And what we do is that we reduce that waste. So, and we really think about preventative. How are we going to get there and do the thing before the bigger thing happens that we have to do 10 more things? So while, yes, we may, those things are revenue creating, we are thinking about the total cost of care. So every time we utilize that, it actually comes against us. So the more that we can do in-house, it's actually cost effective for us because we're doing a lot of extra, you might say, preemptive work to try to avoid that. Like our number one thing is if we can avoid this patient using unnecessary services. So we think about inpatient hospitalizations that could be avoided. That might be going out and to the patient home and giving them Lasix when they start to swell versus when they have 3 liters of extra fluid on them, in which you're probably more likely going into the ER. And what we know about chronically ill patients, I had an old medical director that used to make a joke, our patients go into the ER asking directions to McDonald's and they get admitted because there's a lot of stuff going on with them, right? Like on paper, regardless. And so, every time you increase the likelihood of them getting near the ER, you're looking at inpatient hospitalizations, and then you're looking at potential unplanned dialysis starts, which there's just this whole cascade of interventions. And so when you think about it that way, the cost of one inpatient stay, it's just like mind-blowing how much preventative work you can do for that same. So if we save, one inpatient stay, and when you look at the data, our patients have a lot of inpatient stays. They're using the hospital a lot. So they're, just preventing even a couple and a few patients allows us the reserve to utilize all these different team members and pay them to interact with our patients.
And I think the piece to that too is, and that's where CMS comes in as well as the CKCC model, is because they're supporting that proactive approach to taking care of the patient, right? So they're incentivizing you to keep them healthier and out of the hospital and doing ER diversions and like implementing all of those pieces. Like, hey, like in the per example, like with the patient, we get them on the phone, we know that they're short of breath, we call the provider and they're like, hey, the nephrologist, we're able to get them in for a treatment, get them in a chair, we're able to dialyze them. we just prevented a hospitalization based on that thing. So the CMS model with the readmissions and not the 30 days, 90, whatever that the scenario is, it supports being able to incentivize the providers to do what's best for the patient, which they want to do anyway. But now we're incentivizing them with those different programs.
It's fantastic.
Yeah.
So which patients are eligible for the models? So first, from a model point of view, obviously you mentioned the CMS CK model. Is that the only model you're doing right now, or are there other models in addition to that?
So we have two models. So one is the pilot. It's a 5-year pilot by CMS, which is CKCC. That is the model that allows us to treat fee-for-service Medicare patients more like you would see with a Medicare Advantage population. So the way basically it works is the chronicity and acuity of your patients is reimbursed financially based on an algorithm that I can't intelligently speak to. Someone else figured that out. That says, in general, it should cost this much to care for these patients. Separately, we also are involved in partnerships with health plans, MA health plans, to take on risk for their patients with kidney disease. Those criteria really vary from partnership to partnership, but same idea. From a clinical perspective, we don't think of these patients any differently. That's a great thing with doing what's right for the patient is it's a little bit, of course there are payer discrepancies and nuances, but it's a little bit payer agnostic, and that we know that if we do these things that we're still going to get everyone wants to see hospitalizations reduced. Everyone wants to see more transplants and appropriate use of palliative and conservative care, across the board, no matter if you're an MA payer or CKCC, there's a lot of commonalities because people know what drives costs.
And modality of choice. I think that's the biggest piece, which I absolutely love, is them being able to pick the modality and starting on that modality within reason. Like, they have a conversation with the provider, the access is put in place. There's the journey in which they go is everybody's talking about it. They're on board. It's not them having an event that occurs and they crash. So we use the term crash into dialysis. They hit the inpatient, and that's the first time they're getting dialysis. It's with the central line, which we know is frowned upon. It's not the optimal start for that patient, hence the term. So I think that's one of the best things about it, is shifting to recognize that. I think that's the enhancement with Evergreen that I love, based on what CKCC puts in place for optimal starts. Ours is recognizing within the organization, it's the patient's choice. Like, is that what they wanted, or were they backed into that decision? Like, did they feel like that was the only choice? And that's what I love about when we talk about conservative measures and palliative, like not choosing or not doing, it is a choice, and we need to support them with that. I think being in primary care previously, it's so taboo to talk about those things. You know what I mean? That's why we have doctors that are specific in that line of work of what they do, because let's have a conversation, let's defer to this individual because they don't want to have the hard conversations, and we're supporting the patients through that, which is, it's the first time, and Emily knows this as well, they've said it to her personally, like, it's the first time somebody actually paused and listened to what they had to say.
Yeah.
And I think that's, for me as an RN, I always go into a situation with my medical needs. Like, what do I need that patient to do medically? They have blood work they didn't have completed. They didn't go to dialysis 3 times this week. They only went once. Like, medically, I'm thinking that way. And then the shift with the paradigm of what we're trying to do is, and value-based care, is that what are the barriers for that patient, and what do they want? Because if I don't address what they want first, we're not going to get to what I need them to do to actually help them with their health. It's a constant conversation back and forth, which I love that we are able to pause and take the time with that patient.
And one thing that I think I'm super, super proud of, because it's something that I wholeheartedly believe, I always say this, and the first 3 questions we always ask a patient is, what's on your mind right now? Not like, hey, did you go to that appointment? But like, what's on your mind? Are you thinking about your wife who has stage 4 cancer? And so you're not thinking about anything about your health because she's dying in the bed beside you. And you could really care less relatively about what's going on with yourself because she's the love of your life. What are you most worried about? Are you worried that you're not going to be able to get food? And so this conversation we're having about some kind of access or something that is far in the future is not going to be the first thing until I get that. Are you worried about getting your medications? Are you worried about that you're noticing it's harder for you to breathe, or you're urinating less, or whatever it is? Because if we can understand that, we can get the patient aligned with anything that we want to do. For instance, so how this conversation might sound in like a typical healthcare setting is, hey, we really need to get your A1C under control. Here's what's happening if you don't do it. And sometimes the patients are motivated by that. Sometimes they don't give a rip. Yeah. But how that exact same conversation sounds different in Evergreen Nephrology is, okay, Mr. Jones, I remember that you said like you have a great granddaughter that's going to be born in a couple months. And what you really want to do is be able to hold that granddaughter. Let's talk about that. What I see here is that you have an elevated A1C. What I'm worried about is that's going to increase your risk for da-da-da-da-da and decrease the likelihood that you're going to be able to be there for your granddaughter's birth. Are you interested in talking to me about that and how we might be able to work together to make it more likely that you're there and address these barriers for you? Outcome is exactly the same, but all of a sudden I'm lining with Mr. Jones and he's like, oh yeah, she's helping me, but guess what? Are we going to get good outcomes? 100%. And so it's just getting used to that medical stuff still in the back of our mind all the time, but truly listening to your patients, and they will give you the information you need to have successful outcomes.
I love the patient centricity of this model. I mean, and you're so articulate about all of these amazing interventions. And just thinking about it, there's obviously great assessment tools to identify the needs, and appreciate your point where it's like, okay, we need to be able to match them. In my mind, where I'm going to is, wow, this is so complicated, because if you think about it, you've got all these disparate practices. They're going to have a patient that they're throwing to you. How do you make sure you catch it? And then once you get that patient and you're connecting with them, you're doing these assessments, you have to connect all the dots. And I'm just thinking that if you don't have the right technology and systems, this is going to be an absolute disaster.
Yeah.
And
that's what these patients experience on it. Like they're going to their endocrinologist to manage their diabetes. Some of them are still engaged with their PCP. They're engaged with their nephrologist. And that's where it's a combination. I think it's twofold. It's the technology, and then it's having that person that is responsible for manning the gate. Yep. Like really it's so much about, we tell our teams like, look, you don't have to do everything. You do need to make sure everything is done. Mm-hmm. So that's a really important differentiator, is like, you got to make sure all puzzle pieces fit. And it's not your job to create all of those puzzle pieces, but you got to make sure that they're fitting together. And also, we can't have 25 different goals coming from different people for the patient. There's no way that's not attainable in any way, shape, or form. And so saying like, okay, right now, here in this moment, here's like the 2 or 3 things we're going to focus on, and making sure that everyone who touches that patient is aligned, so that the patient's not like, okay, well, my nephrologist told me this, but then my endocrinologist told me this. Like, well, I'm just not going to do any of it because now I'm just confused. And that happens all the time, even with the increase. So having that person and the technology is a really key partnership.
Absolutely. And like the risk stratification, right? What we're able to build within a system up front, so it's not so manual for the staff. There's key pieces, medication. There's all of those things you can build in that you're able to with the tech piece that would trigger up or prioritize our patients for the highest priority. Like, hey, here's a predictor. This one's really at risk, guys. Like, watch this one. And if we miss it, they crash, right? So, but if we get them, we're able to leverage the tech. We're able to see them sooner than maybe we would have had line of sight on them to be able to get it done.
Yeah. It's amazing that you're developing the tech to be able to make a lot of this stuff work. And I know we really appreciate the partnership with you in doing so, because it really, ultimately, to be able to do this at scale, you have to have a technology backbone. Otherwise, there's just too many pieces and parts. You might get lucky and have one person who's really, really, really good, and they can keep it all together, but it's not scalable. And things fall through the cracks.
Yep. And the platform with Innovase are like being able to task, being able to have a work list, being able to have all those functions. So they
set it and forget it.
Yep.
Yeah.
It's organized. They see where it's at. They know what's coming up next. They're seeing all the ways that the patients that they're interacting with and the next steps they're taking. And then obviously the care plan itself to be able to drive the care. Those are key pieces to be able to organize them. So you're not working out of a spreadsheet. You're working in an efficient platform.
And I think spending more time thinking about less time thinking about who do I need to call and what are the different things, instead of just being like, I know who I need to call and now I can use the reason that I joined this company, which is to talk to patients and help patients. But I think it's really disheartening to be joining a company where you join because you want to do something better for the patients. 99.9% of our staff would tell you that's why they joined Evergreen, and enabling them to spend less time. It goes back to emotional labor. Like, did I forget something? Like, I'm scratching it on my Spiro pad or whatever, and hopefully I don't forget something. But also what's really scary is not so much the patients that are in your face, but who's this one that's coming up behind and is starting to get more and more utilization. And then boom, you don't want to know that only when they come into the hospital. You want to say like, hey, we haven't reached out to this person in a while. And so really moving, I think at the big picture, moving from spending as little time as possible figuring out who to call and what to do, and more time delivering that care is like where the sweet spot and the Shangri-La is.
Oh, absolutely. And that's actually a huge benefit, by the way, for the providers.
Yes.
Because I can tell you, talking to my colleagues, one of the biggest frustrations in practice today is all the time spent doing tasks that are not necessarily accretive to the patient.
Mm-hmm.
And also the time and you know, as you're referring to, emotional energy, mental energy, the time that it's not fun. And not only is it not fun, but you know, at times you feel like you really do want to do these things and you see it. And so I absolutely love what I'm hearing here, because you're able to bring this incredible suite of services. You got the payment in place. It's great for the patient. It's great for everybody's winning. One thing that as I was listening to your model, you know, there's a debate in the industry, the primary care based models versus specialty models. As I was listening to your model though, it sounds a lot more just like a primary care model, with the exception of, you indicated in some of the MA plans. So that's in of and itself MA model, and then you're taking a subset of that. But would love to hear some of your thoughts about this primary care versus specialty. How do you view yourselves? Do you view yourselves as a specialty or a primary care? And how do you view the compare and contrast of the models?
But I think as definitely as a specialty, right? Like our renal docs, they know the kidneys, but I think I truly believe it's a collaboration, right? Like it's not one key player drives all the pieces. I think that's what the whole value-based care program shows. Like, it's love our docs and what they're doing with the patients, but to be successful, you need all the other key players in place. Like, right, you need the social worker, you need the dietitian, you need a pharmacist, everybody in their specialty. So I think there's a lane for both primary care and nephrologists to work collaboratively together. And also, like in the example Emily was giving before, I think one of the biggest things I hear patients say is labs. So their blood work's ordered. They have a cardiologist that has their objectives that they want to order this subset of labs. The nephrologist wants to order them, and then they have primary care that might be duplicating some of them because of the lack of oversight with seeing what's going on with the other. So I think if we all play nice in the sandbox together, and you have somebody that's leading their care, like the NCM who knows this patient, they know what different things are coming in, they're able to advocate for the patient and go to the primary and say, hey, we have this coming up, can we just do one stick? Because if you know anything about patients with kidney disease, like it's incredible to try to find a vein on them. Like, it's a skill set in its own, but like that's a big piece to them. You know what I mean? That small little piece that we can then integrate everybody together. So I think we all need to be rowing in the same direction and having conversations. I think there's enough space for both the specialty and primary care to work together within this space.
Yeah, I totally agree. And like at the end of the day, although I wish this were not the case, there is a lot of sick people in the US. So I'm kind of like, let's all get in. It's not like I have to give up a slice of my pie to get yours. And I think when I was thinking about this question, I was really thinking about how could we like sort of think about how this would work effectively. And I was like, what if primary care worked on preventing kidney disease in the first place? Because what do we know? Hypertension and diabetes are the primary thing. Who should be the first one to know that? Primary care docs. And like, if we were put out of business, I don't know if I'm going to get in trouble saying this, but if we were getting put out of business because we are so effective at managing these disease states early on,
so be it.
So be it.
Yeah.
Mark my words, you know. Yeah. But I don't think that that's also realistic at this point in time, especially with the health disparities we see. And so what if, you know, how do we focus the time, I think, is the real question. And how do we sort of divide that up in a meaningful way so that, you know, primary care docs are looking at how do we prevent even in our healthy populations? How do we say, like, if we don't do anything, these people, we know X number of people are probably going to get diabetes. The numbers are only increasing at this point. So how do we think about not so much who should have it, but who should have what, and make sure that we're really playing to people's strong suits, but also using, to Emily's point, people who are better at doing things to their strong points too. And so I think there's plenty of room to play here. And, again, if we ever get into a situation where we're fighting over patients, that's a good thing, because that means we don't have that many sick patients. So.
Oh, absolutely. Absolutely. Love this. So we've talked a lot around the model, but would love to maybe get a little bit deeper. Tell me about the CMS model. What do you love about it? What are the opportunities for improvement? How do you view that?
So I think I
know it's a complicated
It
question.
is.
And there's lots of layers.
There
to
are.
it.
And I think for me, just the bare bones basics is that CMS is doing these initiatives and they're putting them in front of everybody and saying, hey, this is the standard. This is the expectation. This is what we want you to do. This is when we'll incentivize it when you are able to accomplish that. And for me, it comes back to, and we were actually just talking about this today, is also in conjunction with NCQA accreditation, right? So saying that the program is strong, when the two of them are working in tandem and they're so aligned with what the outcomes are for the patient, like we have all we have is to go up and succeed from it, right? If you just implement and you drive them in that direction, you can achieve that. It's easier said than done, right? It's a grandiose thought, but we can get there with what they have in place. It's a good start to shift everybody from the fee-for-service model.
Yeah, and the way I think about it is they lay the foundation, because at the end of the day, what talks, money talks. And so they create a pathway for us to do the right thing for the patient and get paid for it, like I talked about in the very beginning. I think about the other thing I personally really love about the CKCC pilot specifically is obviously optimal starts getting people on their modalities early, making shared decision-making, that kind of thing is incentivized. The other thing that I think that's been incentivized for as long as nephrology has been around. But what I really love is that another really front and center idea is this concept around PHQ-9s and PAM, which is a patient activation measure. So they're acknowledging, like, yes, this is about the kidneys, but without understanding, is there depression symptoms or other mental health things going on, as well as how engaged is the patient? How empowered are the patient? And that's a very good indicator to other things like hospitalizations and other outcomes. So by putting their money where their mouth is, so to speak, it's really opening the aperture for I'll speak about in our scenario specifically, nephrologists who are often, kidney, because that's their job, but they are starting to care in new ways about these other things that are going to benefit them. But it doesn't rely on them like extending too much hope or belief in, like, when I say, hey guys, by the way, when you treat depression, it's really going to help your other outcomes. It really helps me with that message when there's a financial incentive behind that.
Yeah, and then the data to support it, right? Because we're able to show the correlation between the scores with the PAM versus not even completing it. Like, it drives, and there's a lot of predictors that can say with the stratification, like, hey, this one's at risk. Like, guys, come on, get line of sight on this one, and we need to do something with that patient.
And they also force the follow-up, which I love,
Yes.
because a lot of times historically, it's just like, okay, pay for reporting.
Check the box.
Yeah, check the box.
Move on.
But they're saying, okay, you have to do this, and then we also need to see reduction. We need to see patients that are more engaged and less depressed.
Just huge.
Yes.
Now, one of the things, we touched upon this, I think, throughout from a different thread point of view. Here's the benefit for the providers. But let's say I'm a nephrologist. I'm not involved in any of these things, and I'm listening to this. How do I know, is this right for me? What are the things that I should be thinking about? Like, that this would make sense for me, or maybe this doesn't make sense for me.
Yeah. I think it's your willingness to
Think outside the box.
think outside the box and, like, flip everything you may have known to be true on its head.
Yep.
Or everything, at a certain point in your career, you, like, feel pretty comfortable in what you know and what you don't know. And, hopefully, but, to be saying, like, how willing are you to say, like, hey, you may not know everything about this patient, and we're probably going to find out some stuff you didn't know, because maybe it's something that they're going to tell a non-licensed, non-clinical person that they're not going to tell anyone in a white coat with a stethoscope, right? So like that, being willing to admit that, and like, is that going to be worth it to you? Because, and that whole paradigm mental shift we talked about is a big thing, because, you know, it sounds great. People probably listening to this are going to say, yeah, I want to do this. Less work for me and better for the patients and more money. Like, absolutely. But, you know, as we've said many times, it takes a lot of mental energy to get there and to, you know, let down that guard. And not only, you know, this isn't, you know, the individual, but what's your practice's tolerance for that too? Because you can have really engaged leaders, but if the docs that are treating the patients on the ground aren't into it, it is a rough road, and it's quite literally painful. So, you know, I think those are the questions, and, you know, reach out and talk to someone who's done it. I think that's like the best advice I could give, is say like, they're going to tell you the good, bad, and the ugly, because it's not all butterflies and roses in the beginning. And it takes some storming, forming, norming type things to finally get to the place where the doc can really go to bed and say like, yeah, my team's got it.
And that's what it comes down to. I think it's the trust to know that they are able to hand us their patients, and we're going to do right by them. It's like they have been doing right by them. And it's been incredible to see. We have some phenomenal JV docs that are just like, and you can see it in the markets. Like, you can see it, they're gung-ho, they're advocating, they're like, yes, let's do this. And they're willing to, exactly what I'm, just flip it upside down. Like, let's go in, like, balls to the wall. Let's jump in the pool all together. Like, let's do this. And that's where it's successful, when they're willing. It's a give and take. It's not just always, well, this is the way that I've always done it, Emily. I'm going to continue to manage my patients this way. If we're hearing that, then it's very, very difficult to get them moving in the right direction sometimes, to see the bigger picture, with like shifting just a little bit. Like, hey, okay, I hear what you're saying regarding optimal starts. Can we try this tactic to be able to see what happens with the patients? And ultimately, data drives decisions. And that's where having, you know, Innovisor as a platform to be able to do that, to give them the data to say, hey, I'm not just talking out both sides of my mouth. Like, here's the data to support it. We can do it. This is what we're able to do. And they're like, okay, all right, let's do it.
And I think the thing I think about transforming healthcare, because people get really excited about it. And I think the thing that people fail to recognize sometimes is, when you're transforming and saying the current system doesn't work, there's a little piece of you that has to be willing to say, everything that I'm doing is not the best thing to be doing historically. Yeah. And there's a lot of reasons for that, but that's an ego thing, right? Like, you have to be willing to say, I didn't do it all, and there is something better. Because if you can't say that, then you can't let the rest of us in to support you. And so, like, I say that to not only providers, but anyone coming into this is, you know, if you have been a nurse for 35 years doing care management and you come into our environment, you are going to have to unlearn and do things differently, even if you're a very effective care manager in the dialysis clinic or at a health plan or wherever you're coming from. And so coming into this and being a part of transformation of healthcare means that you also have to transform, and recognizing that doesn't always feel great in the beginning. Usually people get there, but it's a little bit of a shock to the system.
It's a marathon,
for a lot of people,
not a sprint.
Yeah,
absolutely. If we use our crystal balls now, and let's imagine we're, you know, at some point in the future, what's this going to look like?
For me, it's truly, when we talked about it, getting to the place where we are doing so well with the CKD population that we are extending the time that patient gets to end stage. We know it's going to happen. It's just a matter of when it's going to happen, and being able to truly be like, we got this. Your CKD 3B, like, we got you. And here's what you need to do. Here's all the resources. We get the buy-in from the patient. Everything is where it needs to be, and we just keep adding months and months onto the quality of what they're able to do before they get to having to actually activate the modality that they choose. That, for me,
and having a plan all that time,
yep,
right?
Yep.
Like,
and walking them through it.
Yeah,
that's the ultimate goal. That truly is. If we do it right, that is where we'll sit.
And I think also, if I could sit in this chair in 5 years and I could say, my patients know what their plan of care is, and they know their part in it, and they know what everyone else is doing in it. They're aligned on the goals. The goals came from them. They see their words in the mouths of their nephrologist and their nurse and their social worker. and they recognize themselves in their care plan, to me, that would be like the utopian dream.
Rabada.
Yeah.
Amazing. Amazing. So last thing I want to cover is, sometimes it's good to just have like a key take home message. Like if you encapsulate everything that we've discussed, everything that you're thinking about, and you want to turn it into, here's the bottom line message. Would love to kind of hear your summaries, your thoughts, your bottom line messages.
I think for me, it's and we say it all the time, we truly do. And like Emily alluded to multiple times, like it's so easy to say, but to put in action. But if we truly are capturing the right patient at the right time with the right intervention, that's the win.
Yeah.
That's the win. Like that's the overall message is, and how do we do that? We have all these resources in play so that if it's a referral that we're getting for that patient, we know how to tee it up. If it's me as a nurse calling and it's a cold call, I know how to engage that patient. Or if that patient, the first time we're touching them is after, we find out that they're admitted to the hospital and they're being discharged, like those three avenues of like our main interactions with them, like I'm able to pivot quickly using my clinical skills to be able to drive what I need to for that patient.
Amazing.
Yeah. And I think if done right, truly patient-centered care makes things easier.
Yes.
Harder. I think that is something that is not well recognized actually today, because I think we want to do what we think is right and we never get anywhere. Like it might feel better in the moment, but at the end of the day, you don't actually get the outcomes. And I think the patients actually hold the key to how do you get from point A to B, and we're not utilizing them enough. Like we are not making them participants in their care plan. So Mr. Jones, what are you going to do every day to help us get to this goal? Like we don't recognize and utilize that like secret to everything. I don't know. Yeah. It's actually such a simple concept, but it is so hard for people to do that because it's coming outside of our comfort zone, allowing ourselves not to always be right. And even if we are right, allowing ourselves to be like 100% devoted to that patient is difficult. Because it's pounded into our head in nursing school and med school of like, you see this problem, you fix it. You see this problem, you fix it. But that's not working. I think the take home message is that's not working. And we know that because any statistics in healthcare you look at things are getting worse in a lot of ways. And so we have to do something radically different to be effective if we want to change sort of the tides that we're seeing, increased obesity, disease rates through the roof, even though being a first world country with a lot of technology and stuff, like we are missing some really key elements that if we want to be truly world leaders in healthcare, we have to think about differently.
And the piece is an active participant in their care, right? Like that's something I say all the time because I truly mean that. I want a patient that's an active participant in their care. So what does that mean for everyone? Some of them will line right up and be like, give me the resources. I'm game, Emily, let's go.
Yeah.
And the other ones is what does an active participant in the care mean to them? Like that's actually where we're starting. So we're meeting them where they're at, their level of understanding and knowing where it is, and then, swinging the pendulum as far as we can to get them to where we need to be.
Well, I have to tell you that I'm in love with your model. I mean, it is just... And both of your passion for this is absolutely infectious, and it truly is an honor and a privilege to be your technology partner, enabling you to do this. I think the way that we think about this is in some small way, the care that those patients are getting, we're facilitating and enabling it, and that's a privilege for us, and we're really excited that we're able to take these ideas and concepts, bring them to life, and be able to really make a big difference for the patients and providers. So thank you.
Thank you.
Thank
It was
you
an
for
awesome,
partnering with us. Yeah.
Absolutely.